So we're still on normocytic anemias. We're talking about intrinsic hemolytic anemias. And just remember that overall, we're on the bottom right, we're normocytic anemia still. And out of the either hemolytic versus non-hemolytic causes, we're looking at hemolytic. And remember, if we break down hemolytic, we're looking at the intrinsic causes. And we're ready to talk about 4 of the intrinsic causes. This is the next one. This is sickle-cell anemia. This is due to an autosomal recessive mutation of a single amino acid in the hemoglobin beta chain. And this mutation causes mutation of the hemoglobin A to hemoglobin S. Due to that single mutation, the single mutation here is a mutation from the amino acid glutamic acid to valine. So the big problem here is that glutamic acid is hydrophilic, valine is hydrophobic. So we just switched a hydrophilic amino acid in this beta chain to a hydrophobic amino acid, and that's going to mess up your structure a lot. And that's going to cause a lot of problems. Now the thing is, remember, this is an autosomal recessive problem. So you need mutation in both of your genes to get sickle cell anemia. If you're a heterozygote and you only have a mutation in one of these genes, you actually have resistance. Well, this gene in general gives you resistance to malaria, and you only need one of it to get resistance. So that's why this gene is carried by 10% of African Americans, because it was a protective effect. Having this gene helped you not die from malaria, not even get malaria, not die, and so you could pass your gene on. And so a lot of descendants have this gene, and when your descendant gets to two of these genes, gets a pair of them, then they get sickle cell anemia, which is not great. So what happens is you get this hemoglobin S now due to this defective beta chain, and this hemoglobin S can polymerize when it's deoxygenated or when it's too high of a concentration. So when it polymerizes, it's going to lead to the formation of the red blood cell to a sickled shape. So you have all this hemoglobin. This is the sickle shape, by the way, on the right here. So that we have hemoglobin in the red blood cell, and when it's deoxygenated or high concentration, it ends up polymerizing, and it causes the sickling of the shape. So what are some cases of when hemoglobin will become deoxygenated? Remember that? We talked about this in the pulmonary lectures. We're talking about the hemoglobin curve. Remember, this is the sigmoid shape of the hemoglobin curve. And remember, things that cause it to deoxygenate, or that is shift to the right, remember, shifting to the right means it unloads more oxygen, where things like higher temperature and acidosis. And that means your body's working harder. It needs more oxygen. And working harder, there's a lot of metabolism going on, so that's why there's energy, there's temperature increase, there's acid, there's lactic acid, so it needs oxygen. So hemoglobin will become deoxygenated, drop off its oxygen. So those are the causes of deoxygenation. And causes of too high a concentration include when patients are dehydrated. So when they're dehydrated, their red blood cells they also dry out, and your hemoglobin concentration goes up, and then you can get sickling. So the problem is that your sickled red blood cells can cause occlusion of blood vessels, and that's going to lead to symptoms. The other way it causes problems is it gets hemolyzed. It gets either hemolyzed in the blood vessels, so intravascularly, just because it's just structurally poor, or it can get hemolyzed extravascularly, because I told you, extravascular hemolysis occurs when there's something structurally wrong with the red blood cell. You can tell obviously there's something very structurally wrong with this. So, 2 ways you get symptoms: occlusion of vessels or hemolysis. The final thing to know is that the infants are asymptomatic. They're not affected even when they have 2 copies of this gene, because they have high levels of hemoglobin F, which protects against sickling. So remember, hemoglobin F is alpha and gamma. So alpha, gamma. So again, you don't need beta chain here. So your hemoglobin F is fine and protects against sickling. So clinical features here all relate to this occlusion of vessels and hemolysis. So this is how let me clear these first. And just to show you, this is how you have normal red blood cell flow here, and you get sickling, and you get occlusion of blood vessels, and that's how you can get some symptoms. So first of all, we'll look at hemolysis though. You get severe anemia due to the intra and extravascular hemolysis of sickled red blood cells, and you get resultant lab findings. So what were the lab findings we talked about with intravascular hemolysis? Right, I told you, you have the increased hemoglobin in the blood in the urine, and what happens to that haptoglobin? Remember, haptoglobin goes down because it binds to the hemoglobin, and then LDH goes up because it's released from the cells, and you have extra indirect bilirubin. And then extravascular hemolysis also gets you a lot of that indirect bilirubin, and that's going to cause symptoms. Remember what symptoms you get from too much indirect bilirubin. You get You get the jaundice of the skin. You can even get pruritus, that's itchiness of the skin from bile acid deposition. You can get bilirubin gallstones. And the next thing is going to happen, because you have severe anemia, so you're going to have anemic symptoms too because of the hemolysis. You're going to get erythroid hyperplasia. And you're going to have basically increased production both inside and outside of the bone marrow. So you're just trying to make more red blood cells to compensate for the severe anemia. You're going to have such severe anemia that, first of all, your bone marrow is going to kick into overdrive. So you're going to get the crew cut appearance on the X-ray and chipmunk facies. So that's from too much production in the skull and the facial bones, so they're going to enlarge. And the other thing, you're also going to increase production outside of the bone marrow, just because you need to muster all your red blood cell producing forces. So you're going to get production in the liver and the spleen. Remember, we kept talking about that. So those are going to expand. You're going to get hepatosplenomegaly. So that's it for the hemolysis. Next is the vaso-occlusive symptoms. So you can get vaso-occlusion in the chest vessels. You get acute chest syndrome. That's symptoms of chest pain, respiratory distress. Dactylitis is a fancy term for occlusion of vessels in the bones of the hands and the feet. So you occlude vessels to the bones of the hands and the feet. You're going to get bone pain and swelling of the hands and the feet. You're going to get occlusion of vessels to the kidney. You get renal papillary necrosis. And especially you get sickling in the renal medulla. Remember, the medulla is the inner part of the kidney. And that's because there's decreased oxygen in that area. And this will present with some microscopic hematuria. I just want to add that I noted these three places: the lungs, the bones of the hands and feet, and the kidney. But you can get occlusion in pretty much every organ, and then you're going to get ischemic symptoms from those. So far we have hemolysis, we have vaso-occlusive symptoms. Finally, you can get infections from encapsulated organisms. So for example, strep pneumonia is probably the most common one. And this occurs due to functional asplenia. What does that mean? It means that, asplenia means you don't have a spleen. But this is a functional one. So you technically do have a spleen, it just doesn't work. That's a functional asplenia. And that is because of the vaso-occlusive symptoms. So you get sickling of the vessels in the spleen, and it causes infarction of the spleen. So the spleen dies, it doesn't work, you have functional asplenia. So now you get infections because the spleen we usually use to clear out encapsulated organisms. But these patients are going to be at risk of infection for encapsulated organisms. So overall, big picture clinical features: hemolysis, vaso-occlusive symptoms, infections. Alright, labs, what are we going to do? We're going to get a hemoglobin electrophoresis, and you're going to see presence of hemoglobin S. So hemoglobin electrophoresis, if you ever worked in a lab, in a wet lab, you would know what it's like. The agar gel, and then you have a different charge. There's a negative charge and a positive charge, and you basically run stuff through the agar. And how fast they move depends on how much charge they have. They're going to be attracted to the opposite charge. So we run red blood cells through the agar, and then you can see the hemoglobin separate out because they have different charges. So how do we treat this? We treat this with we can give hydroxyurea. That increases levels of hemoglobin F in the red blood cells. So remember, we said that hemoglobin F increased levels are protective against sickling. And then the next thing you can do is you can hydrate properly. What I tell you about hydration, remember that hemoglobin S can polymerize and sickle if it gets too high of a concentration. So you prevent that by hydrating. You get more fluid into the red blood cells. You reduce the hemoglobin S concentration. So that's it for sickle cell anemia. Next, we're going to talk about hemoglobin C disease. This is basically a less mild version of sickle cell disease. Similar mutation. It's a mutation that beta globin gene is, but instead of the glutamic acid, but this one is going to turn into lysine. Okay, and we actually normally spell it like this. I think actually I spelled it wrong. So lysine. And this is less mild because, remember, what do we say about glutamic acid? Remember, it was a hydrophilic, and lysine is also hydrophilic. So you're substituting hydrophilic for hydrophilic. So there's not going to be too much of a change in your beta globin protein. So you're going to have less, basically more mild symptoms, actually. More mild. Poor grammar, sorry. So the problem is, so now you get hemoglobin C instead due to this mutation. And this hemoglobin C is less soluble in the red blood cells than hemoglobin A is. So what happens is less soluble, so it can precipitate into crystals. And so now you have less hemoglobin in your red blood cells because now it's in crystal form, so it's not going to work. So you're going to have decreased oxygen binding capacity, and so you're also going to have increased fragility in your red blood cells. So clinical features here. Sorry, I just talked about this. Clinical features, you have increased fragility, so you can get hemolytic anemia. And I told you the hemoglobin precipitates. Hemoglobin C precipitates, you get hemoglobin crystals. So that's hemoglobin C disease. Again, just a more mild form of sickle cell disease. And then the mutation here is glutamic acid to lysine rather than in sickle cell. What did we say it was? It was glutamic acid to valine. And remember, valine was hydrophobic. So now we're going to go into the hemoglobin electrophoresis. And so we're going to look at the findings. What hemoglobin will we see in sickle cell and what hemoglobin will we see in beta thalassemia, which we've talked about already. Remember, that was a microcytic anemia. So normally we have hemoglobin A. That's for adult hemoglobin. 95% of the hemoglobin in our red blood cells is hemoglobin A. And then hemoglobin A2 we have around 2.5%. Depends on the patient. And this is, remember, this is the alpha delta globin chains. And then remember that fetal hemoglobin we usually see in the fetus and newborn infants. You can see a little bit of it in adults. This is the alpha gamma chains. And then hemoglobin S, normally we shouldn't have hemoglobin S. A normal person wouldn't have any hemoglobin S. I just want to emphasize that these red blood cells, when they have hemoglobin, doesn't have to be, this red blood cell doesn't have to only have hemoglobin A. It can have some hemoglobin A, can have some hemoglobin A2, can have some hemoglobin F, and just remember that the majority though will be hemoglobin A2. But if patients who have sickle cell trait, what is sickle cell trait? Remember, that's when you have one copy of the mutated globin gene instead of two. What's going to happen to your adult hemoglobin levels? I mean, the problem with the sickle cell trait is that you have defective hemoglobin A because it's defective in the beta chain, so you're going to have decreased levels of this. Now, you only have one defective gene, so it's not going to be too bad. It's only slightly decreased. And what about hemoglobin A2? This is going to be normal. Nothing's changed. Hemoglobin F is going to be near normal. And then hemoglobin S, what's going to happen? Are you going to have hemoglobin S or not? You're going to have a little bit of hemoglobin S. This is because of that mutated gene, which is the mutated beta gene, you are still going to get a little bit of hemoglobin S. You're just not going to get too much, so it's a little bit elevated. Now, what happens when you have sickle cell disease? What happens to your adult hemoglobin levels? Are you going to make enough beta chains to make your alpha beta hemoglobin? Remember, adult hemoglobin is alpha beta. Well, you have defective beta chains, so now you're going to get hemoglobin S instead. So you're going to have pretty much absent hemoglobin A. What happens to your hemoglobin A2? Nothing's going to change here because you still have alpha chains, you still have delta chains. What's going to happen to your hemoglobin F? Remember what I told you about hemoglobin F in sickle cell? Remember, hemoglobin F is protective against sickling, so your body's going to want to make more of it and not sickle. So you're going to get a lot more hemoglobin F in these patients. And hemoglobin S again, then we just talked about, I said you get a lot more of that, so you get a lot more hemoglobin S in sickle cell disease. Now, beta thalassemia, what was the problem in beta thalassemia? Remember, the problem was we have a defective gene for the beta globin. So if that gene is defective, what happens to your hemoglobin A? Right. Hemoglobin A is alpha beta. You have defects in this. Small defects, you get small decreases in adult hemoglobin. What's going to happen to your hemoglobin A2? In beta thalassemia, you're going to upregulate that. There's nothing wrong with alpha, nothing wrong with delta. You get more hemoglobin A2. What happens to your fetal hemoglobin? This is near normal. And this doesn't change because it doesn't really have a protective effect. There's nothing to protect against, so it's not a problem. You're not going to have more of it. And then how about hemoglobin S? Well, you don't have that mutation of that. What was the mutation? Just to test you. Glutamic acid to valine. You don't have that mutation, you don't get hemoglobin S. Finally, beta thalassemia major. The problem is you're missing both of those beta genes. You have no beta globin production at all. So what happens to your hemoglobin A? You have no absent hemoglobin A. What happens to your A2? It goes up a lot. That's compensate. Hemoglobin F is also going to go up. This is compensating again. And then this one, still nothing. So I just want to point out that what you're going to see in these diseases, especially sickle cell and beta thalassemia, you're going to see missing hemoglobin A in both of them. So the way you have to differentiate them is you look at the hemoglobin A2, or you can look at the hemoglobin S. And sickle cell obviously has a lot of hemoglobin S. Sickle cell is very easy. I mean, that's what sickle cell is. The problem is because you have hemoglobin S. and then beta thalassemia would be the one with increased hemoglobin A2. So that's how you can help differentiate the two with this hemoglobin electrophoresis. So that's it for our second part. We talked about sickle cell trait, sickle cell anemia, hemoglobin C. This is the remainder of the intrinsic hemolytic anemias. The next lectures we're going to go on to the extrinsic hemolytic anemias. So remember, these are normocytic anemias. These are hemolytic. That's due to destruction of red blood cells. And we're going to talk about the extrinsic causes. So on to the next one.